a trial of mass isoniazid preventive therapy for tuberculosis control.
All the echocardiographic parameters are improved after
Tuberculosis or
getting
TB
spironolactone.
disease.
So
TB
a vision
is
of
spread through the
HFpEF
air from one
is
person to another.
someone with a history
When a
of
person
hypertension
breathes
or
in
diabetes
TB
or
bacteria, it can
who has
settle in the
equipment
lungs and begin to grow.
stiff, non-compliant,
It is caused
with
by
fibrinosis.
Mycobacterium
And
tuberculosis, which usually attacks the lungs. It can also attack any part of the body, including the kidneys, spine, and brain. It can be fatal if not treated properly.
Some people have serious side effects from TB medications. Should you develop any, you must call your doctor or nurse right away.
Not only hasn't it worked, the projections are that HFpEF will soon be the most frequent cause of heart failure because our elderly population, obesity, and diabetes. So I'm going to ask Mark to tell you what we really did.
Well, fortunately, the National Heart, Lung, Blood Institute agreed that this is
Are
a
the
huge
symptoms
unmet
of
need and
tuberculosis?
funded through a contract. This
It is
research,
a pleural
and we did it
effusion,
with, in collaboration
collection
with
of
the
fluid
Medical
between the
Research
lung
Institute.
and chest wall.
And really, the concept was, let's
The symptoms
take people who
include
have signs and symptoms
cough,
of and an
chest
ejection
pain,
fraction greater than 45%.
shortness of breath,
Then we
fever, sweating at night, poor appetite, weight loss.
Definition. Tuberculosis is a leading cause of death in adults globally and was responsible for an estimated 1.4 million deaths in 211.2 human immunodeficiency virus (HIV) infection.
I was interested in the health science administrator position, and I specifically was interested in the program officer side because having been a scientist in the outside world and conducting research, I didn't want to get away from science too much. Basically, what it allows me to do is be involved in the bigger picture. I'm able to actually work with my colleagues to help shape the whole field. So at first, I was a little nervous when I came into this position because its title is health science administrator, and I was a little nervous how much administration would there be. And I've actually been really pleasantly surprised. A lot of what I do on a day-to-day basis is still very scientific in nature. To be successful as a program officer, you need to be flexible. Your day is never going to be the same from one day to the next. While we do have some administrative aspects of what we do, the fun things that we get to do are we get to plan workshops, we get to bring in scientists from all over the world, and so you've got to be willing to jump into an opportunity and just kind of go with it and see where it leads.
The purpose of this tutorial is to educate the community about tuberculosis.
Hi, this is
What
Clyde
is
Yancey
tuberculosis?
at the 2013
Tuberculosis is
American
a
Heart
disease of the
Association
lungs caused by
Scientific
germs.
Sessions,
These
and I'm
germs
delighted
are
to
spread
bring
into
you
the air
science
when an
news
infected
from
person
Scientific
coughs.
Sessions. This afternoon we have the privilege
How is
of
tuberculosis
discussing the
distributed?
results of the TOPCAT study.
In
with the
Uganda,
principal investigators.
tuberculosis is more
This
common
highly
in western
anticipated
Uganda
and very
and less
much
common
needed
in other
study
parts of the
really
country.
addresses one of the
However,
most important
worldwide,
dilemmas we have in
tuberculosis
contemporary
kills
cardiovascular medicine.
60% of the
How do we
infected people
treat
who are
the
not
patient
treated.
with heart
This
failure with
amounts to
preserved
3
ejection
million deaths
fraction?
every year.
I'd like to welcome Mark Pfeffer and
Then,
Bert Pitt.
what causes
First, I'd like to
tuberculosis?
congratulate you, man, for your
You
extraordinary
see,
effort in a
tuberculosis
very
is
important
spread
trial.
from person
Let's
to
get right to
person
the heart
through
of
the
matter,
air
so to
when
speak.
coughing or
Just
sneezing
tell us
and in the
exactly
process
how was
infecting
the trial
others. It may
designed and
also
what were
be
your
caused by
objectives when
drinking
you did the
unboiled
study?
milk, normally
Well,
from
the
an
trial
infected
was a
cow.
randomized placebo-controlled trial of spironolactone
Risk
based on
factors may
his
include
pioneering work
alcoholism,
in
where
reduced
excess
heart failure
alcohol
and
weakens the immune
post-MI.
system.
That was
Close contact
the
with an
rationale
infected
plus all
person,
the
smoking,
mechanistic studies that
living
Bert can
in
tell you
crowded
about.
living
But with
conditions,
that, should we leave that on the
malnutrition
table
in
for the
children,
handful of
and
patients
diseases
who
that
have heart
weaken
failure
the
yet
immune
preserved
system,
ejection
such
fraction?
as
We said
HIV/AIDS.
no. The NIH agreed, funded it by contract, and we did a 3,445 patient study, randomized to either spironolactone at a dose of 15 hoping to get to 30. You were able to go to 45, average 15 on median 15 against placebo.
So, Bert, what was the background? Why an aldosterone antagonist in this patient population?
Well, if you have a view of the pathology in your mind of heart failure, preserved ejection fraction, I think a lot of us believe there's diastolic dysfunction, fibrosis, and hypertrophy, and mineralocorticoid receptor antagonists, spironolactone and clarinone, have been shown to block fibrosis, reduce left ventricular hypertrophy, reduce myocardial inflammation, left atrial size. So we thought this would be ideal in this population where hypertension is the precursor overwhelmingly, though diabetes and age are also. And so our hypothesis was that spironolactone would reduce the diastolic dysfunction, fibrosis, and LV mass, as well as vascular stiffening, and that should lead to a good outcome.
So, Mark, Bert just used a very interesting phrase. This population, who are these patients? How did you identify them?
You know, we have to give credit to CHARM for actually saying they exist. Well, epidemiologists said they exist, but no one wanted to try it because it's hard to prove they have it. But signs and symptoms of heart failure, if you find people like that, no matter what their ejection fraction, they're going to get rehospitalized and they have a higher risk of dying
the methodology
than just
for
somebody
the
with
modern
hypertension or
randomized
diabetes. That's been
controlled
shown.
clinical trial, the real gold standard for the assessment of evidence-based medicine. A key figure in that story was John Crofton.
So, hello.
I had the great pleasure in this film of meeting him, now in his late 90s. What were the key features of this trial, the streptomycin trial, that make people point to it as being a turning point in the development of trial methodology?
Well, because it was the first really famous international. I think the NCHM told me that before the war there'd been one or two international trials on malaria, and certainly Philip Darcy Hart had done a controlled trial, I think during the war, on some sort of drug for the common cold.
Patulin.
Patulin, that's right. But the one exception, it didn't have randomized distribution. So this was the first really well-controlled trial, and of course...
Although a significant portion of people with heart failure have preserved ejection fraction, none of the proven heart failure therapies has been shown to be beneficial in this important and growing heart failure subpopulation. Now a new NHLBI-funded study has failed to find a benefit in this group for spironolactone, which is a cornerstone of therapy for heart failure patients with reduced ejection fraction. But trial investigators and heart failure experts believe it is too early to dismiss hope that spironolactone and other aldosterone antagonists may eventually be found to work in this population.
Should be explained. Systems that minimize the time for positive microbiologic results to tuberculosis treatment are needed. Continuous isoniazid preventive therapy should be considered for persons at highest risk for tuberculosis, along with strategies to maximize retention. Mathematical modeling may help identify combinations of strategies that are more likely to control tuberculosis in gold mines.
Bienvenue à cette création média de CUSM. Welcome to this MUHC MediaCast.
I'd like to welcome everyone to this Montreal Chest Centennial event that coincides with World TB Day. So I thought I'd do it by the minute because I thought it's sort of these numbers are hard to keep in your head. So every minute, 3 people die of TB globally.
Hello and welcome to the European Heart Journal. My name is Gerhard Hendricks and I'm sitting here in Davos, Switzerland for the 2013 Cardiology Update Symposium. And it's my privilege and pleasure to welcome Professor Bertram Pitt, who is one of the founding fathers of this symposium.
So
Bertram, when did you start with Cardiology Update in Switzerland?
Well, we began planning this somewhere around 1973. I was at Johns Hopkins University at the time in the cardiology division, and I spoke to my chief, Dr. Richard Ross, about putting on a course in Switzerland, and he said fine, and he had a former fellow, Dr. Paul Wicklund, who was from Zurich, but had returned to Europe, and I think
So that's where
we had the first course in 1975.
Then there's also
I think
the drug-resistant
by that time,
forms.
Paul Licklin had
It's
already gone to
estimated now that
Hanover
of
as
every
chief of
6
cardiology.
cases, new
The first
cases,
course
people
we
who've
thought
never
was a
been
great
treated
success.
before,
There were only
about 1 out of
75
6
participants
have
here,
some form of drug
but
resistance.
everyone
They
enjoyed
don't
it.
all have
And at the end
MDR,
of that course,
but
we
MDR-TB
said, well,
is a
maybe we should
more
do it
resistant
again.
form,
But we
multi-drug
didn't want to do it
resistance,
every year because we
which
didn't
is
think
very
there would be
difficult to
enough
treat.
new changes.
And on top
So
of
we
that,
said,
now
let's
in
do
many
it
countries of
every
the
other
world, there
year.
is this
And
XDR,
gradually over
or
the years,
extensively
it's
drug
grown.
resistant,
I think
which
2
is
years ago,
resistant
we
to
had
the
about
drugs we use
850
for
people
MDR.
here.
So
And
that is the
I
group
think that
that's
just
now
shows
really
the
virtually
quality.
impossible to treat. So
I
this
think in the
phenomenon
past,
of drug resistance is
to be
also
honest,
emerging
several
worldwide.
drug companies would
and
pay
it's
for people to
complicating
be
TB
here,
control everywhere.
but in these days, drug companies are not doing that, and the people who are here, and this year it's over 550, are paying their own way, and that shows they're getting something from it.
Exactly. It shows that it's attractive, it's unique. What creates this special atmosphere here in Davos?
Well, I think if you go to the national meetings, American Heart, American College, ESC, there's a tremendous amount of information. But I always feel I'm in the wrong place at the wrong time. There are so many things going on, it's hard to focus. Here, there are main sessions, there are some satellite sessions, but you can sit here for the week and really get a good refresher course in cardiology. The other thing, I think we've changed a few careers along the way. We've changed clinical practice. And for me, as a clinical investigator, coming to these meetings, I meet outstanding faculty, and we create new ideas and new research. Just at this meeting, I formed 2 more new collaborations. Maybe they'll never happen, but we have ideas. We're trying to see whether we can make it work. And I think that's the fun, small atmosphere where people meet each other.
Welcome to Second Opinion Stat, health information you can use anywhere, anytime. Brought to you by the producers of the PBS Health series Second Opinion. Here's your host, Dr. Peter Salko.
I'm here with Dr. Mike Eisman, tuberculosis physician, the National Jewish Medical and Research Center, and Dr. Paul Levy, pulmonary specialist at Monroe County Health Department. Welcome to you both. The first question I've got, I think, is very straightforward. 1/3 of the world, 1/3 of everybody in the world has been infected with TB at some point or another. Just an astounding number. With that much TB out there, how do we protect ourselves?
Well, here in the United States, we've been the fortunate recipients of excellent public health. The incidence of infection for American citizens is approximately 10 million out of nearly 300 million population. The rate of tuberculosis here in the United States is under 5 cases per 100,000 per year. By contrast, South Africa is 500. So we are relatively less exposed. There are pockets, however, in which TB still is prevalent. Over half of our cases occur among new immigrants, so individuals working with or schooling with new immigrants should have a higher awareness. I would point out that it's unlikely to be transmitted with casual exposure. It usually takes days and weeks in the same home for transmission to occur.
But again, I mean, the disease is here. It's an infectious disease. Are there some nuts and bolts things that people can do to reduce their chances below what is admittedly an already fairly low rate in this country?
That gets into just awareness of an individual's risk. And unless you enter into one of these pockets where you have higher chance of exposure, if you're working with the underserved, if you work in a healthcare environment, work in a nursing home, work with new immigrants into the United States, those areas should have some depth or some screening program for people in that environment. But we have to be cautious, although we want to be very vigilant about preventing TB. If we start screening the masses, that is, people at low risk, we're likely to have more false positives show up. That is, the testing is just not an exact science, and really be over-treating people who in general have low risk and in fact never were infected in the first place.
But if your advice is to be careful around immigrant communities, low socioeconomic communities, isn't that a recipe for social disaster?
Disease. Tuberculosis is an infectious disease that usually attacks the lungs but can attack almost any part of the body. Tuberculosis is spread from person to person through the air. Someone with tuberculosis disease is sick and can spread the disease to other people, and person with tuberculosis disease needs to see a doctor as soon as possible. It is not easy to become infected with tuberculosis. Usually, a person has to be close to someone with tuberculosis disease for a long period of time. TB is usually spread between family members, close friends, and people who work or live together. TB is spread most easily in closed space over a long period of time. However, the transmission is in an airplane, although rare, has been documented. Even if someone becomes infected with tuberculosis, that does not mean they will get tuberculosis disease. Most people who become infected do not develop tuberculosis disease because their body defense protects them.
Hi, I'm Charles Prober.
And I'm Morgan Thies.
And today we're going to talk about the pathophysiology of tuberculosis. That is, how tuberculosis makes people sick.
Great.
So in this cartoon, there's an infected individual shown on the left, and that person is coughing or sneezing, and all those little small white dots are particles coming out of the person's mouth. And if this person, and the person on the right, is a non-suspecting individual who is susceptible to infection with TB. Now the person on the left, when they cough, if they have tuberculosis in their system, then some of those bacilli will cough out and enter the person they're coming into close contact with, enter in the droplets. And some portion of those infected droplets, estimated to be about 10%, go all the way down the susceptible individual's airway and land in the lung. They have to be very, very small to get to the most distal portion of the lung called the alveoli. So they have to be around 5 or 10 microns in diameter. Once those bacilli have entered the person's lung, the host, the person's immune system, kicks in at the local level. And the first part of the immune system to greet these bacilli are macrophages that line the lung airways. These macrophages take up the bacilli, and within the macrophages, the bacilli may reproduce, that is, increase in numbers. The macrophage may then release the bacilli. Other macrophages will pick them up, and eventually one has a number of cells in this distal part of the lung that are infected. When these macrophages then come together and lung destruction occurs in the mixture of this, they end up forming a particular kind of lesion in the lung called a granuloma.